Welcome to episode 2 of Community Health Worker Data Dialogues, the podcast where we dive into how data is transforming community health worker programs around the world. I'm Dr. James O'Donovan, Director of Research at Community Health Impact Coalition, and I'm joined by my co-host Dickson and Seema Mbewe, a community health worker from Malawi. In this episode, we're going to be joined by Dr. Karen Finnegan from Pivot Science and Professor Shobhana Nagraj from University of Cambridge to discuss the critical role of co-design in building data-driven community health worker programs. But before we dive into that conversation, let's hear from some of our community health worker colleagues about their experiences, or sometimes the lack of them, when it comes to being involved in program design alongside implementers.
Community health workers are going to give you the first-hand experience in what is happening on the ground, where pandemics and outbreaks start and stop. We are there in the middle. That is how important and how critical it is. Because if a community health worker is right in the middle of where pandemics start and stop and is not involved in anything, then nothing is done. Nothing will be done, and we are not going to get to the Vision 2030 of the universal health coverage. We cannot have universal health coverage if there is a health worker down there that is not recognized, seen working in the bush, but nothing else. I can give you an example of a Marburg, the Marburg outbreak that happened in Tanzania. That is sometimes like 3 years ago. Is it 5 years ago? A 24-year-old girl, community health worker, who lived at the borders of Uganda and Tanzania, went to visit a family. And in the span of around 7 months, 7 family members died in that village. And this lady, just by a phone call, by a phone text, reported this to the Ministry of Health in Tanzania and said, there is something happening here. 7 people died within a very short span. So when the Ministry of Health Tanzania came down, they found that there is an outbreak of Marburg. And that is how the whole world is safe from the Marburg. That is how important a community health worker is. So if you take this community health worker and put them at the decision-making table and maybe to participate in designing, in co-designing, I think they will give you the first-hand experience, which is being missed even up there.
Now, let's go back to the studio to hear from Shobi and Karen.
Shobi, Karen, thanks so much for joining us. It's really exciting to have you here in the studio with us today. Shobi, just starting with you, could you introduce yourself so that listeners can know a little bit about you and the amazing work that you've done?
Thanks, James. So my name's Shobi. I'm an assistant professor in primary and community care at the University of Cambridge in the UK. And I've been working with community health workers since I was about 17.
Wow.
So quite a long time now, I won't give that away.
That's amazing.
And it's been a lovely experience, first of all as a clinician and then as a researcher.
Fantastic. And working with community health workers I know you've done amazing work all over the world, but if you give listeners an idea of where you've worked.
Cool. So mainly in India, but also I've worked in Malawi, which has been great, and more recently in Indonesia and Vietnam and in Australia as well.
Amazing. Thanks so much, Shobi. It's great to have you here.
Thanks.
Karen, also, if you'd like to introduce yourself, that'd be fantastic.
Sure. Thank you. My name's Karen Finnegan. I am the managing director of Pivot Science. Pivot Science is the research arm of Pivot. It's an NGO that works in Madagascar to strengthen the public health system. And I'm a research associate at Harvard Medical School.
Amazing. Karen, thanks so much for being here today.
Yeah, welcome again, Karen and Shobi. The first question would be, what inspires you most about working with community health workers? So let me start with you, Karen.
Thanks, Dickson. Well, in Madagascar, where people have to walk many hours to reach primary care health facilities, community health workers who are embedded in their communities really provide essential primary care services. They're the best frontline workers, and their commitment to providing high quality care is inspiring.
I completely agree with what Karen's just said. And I think it is that that dedication and knowledge of local communities, and over time seeing those gradual changes. And community health workers have that really in-depth knowledge. And so they can see changes happening over time, and then we can have early interventions if we need them as well.
That's great. And Shobhi, I wanted to ask, at what point did you realise that involving community health workers in the design of programs, what we call co-design, wasn't just important, but it was essential for program success?
I think really working as a clinician, first of all, in really rural areas of India, you realise that actually to make a difference in communities, you need to have people that can have trust within those communities and are able to actually interact with people within the villages, for example. And community health workers seem to have that local knowledge. They've built trust with communities. They're from the communities themselves. And so when we're thinking about any sort of health programme or designing interventions, without their input, it won't be sustainable, and it really won't be taken up by the communities either. So I learned fairly soon that actually we needed to involve community health workers when we're designing interventions. And also there's cultural beliefs and practices within certain regions. And so community health workers can help with that local knowledge as well and understanding.
No, that's fantastic. And Karen, yourself, was there a particular point in time when you had this realization that involving community health workers was important? I know Pivot do incredible work in Madagascar, and I'd love to hear some insights into some of the community health workers that you work with closely there as well.
Yeah. I think about 15 years ago, I was working in Rwanda, and we were thinking a lot about community health worker data collection and how we could design tools that would collect the data that we needed to monitor a health systems intervention. But community health worker input was essential to make sure we weren't creating these tools that were too burdensome, that didn't measure what we wanted to measure, that weren't useful for community health workers. And so I think getting their voices involved in that design was really essential.
I didn't actually know that he'd worked in Rwanda. We can talk about that much more later on, but I just wanted to get your perspective as well. So we've covered here that community health workers and involving them in co-design is really important. But we often know that community health workers are left out of this process, either intentionally or unintentionally. In fact, we did some work recently with Community Health Impact Coalition. Karen, you were one of the co-authors on this, as well as Dickson, around the involvement of community health workers in research projects, specifically research that was focused on community health workers. Karen, I'd love for you to share a little bit about that work and some of the findings, just to help sort of ground us in the current state of evidence.
Sure. As we all know, there's a growing body of work around community health research and information about how community health programs are functioning and their impact. And so the research team at Community Health Impact Coalition did a scoping review where they reviewed studies that were published in the last 5 years that looked at community health workers and community health programs. And they identified more than 2,000 articles that were related to these topics. They contacted the authors of these papers to ask questions about the co-authors and were there community health workers involved in the studies and how. And they had some really interesting findings that highlighted what we suspected, that community health workers are often not meaningfully engaged in research or their contribution isn't fully acknowledged. And so I want to make sure that I get these numbers right. But we see low involvement of community health workers in study design and dissemination. Only 7% of studies had community health workers involved in study design, and only 2% had them involved in dissemination. And community health workers often play a role in implementation. So 45% of authors reported that community health workers were involved in implementation of the studies. But community health workers researchers were named as co-authors on only 15% of the papers that we found, and acknowledged only 32% of the studies. So although community health workers are often involved in some way in this research, it's very often not formally acknowledged.
We've heard these shocking statistics which have been published, but it's also important to hear the lived experience of community health workers themselves. With this in mind, let's hear from Bernard and Mishi, community health workers from Kenya and Rwanda, about their first-hand experiences.
They came to our community, I can remember, and they took something like around 1 week working in the households. Mm-hmm. But then what I would say is that up to date, I'll say that I did not understand actually the effect of that research that they did in the community because there were no feedback. They said they were supposed to give us the feedback right from the community health level to the household level, but it was never done. So I would say that at times the research are done, but the feedback are not given. So that one, I can say impacts negatively on the community itself, because you'll find that even when you go for another round with another organization to do maybe a different type of research, you find sometimes the household members resist.
Sometimes researchers, they come saying, we are researchers, we are researching on this and this in your community. Please, can you help us to collect this information? You, as community health workers, I have to support them and get the information they're looking for upon asking approval from my supervisor. Then after there is no further step. I just give the information, but I didn't see them coming back for community health workers and all community members to share the result from the data we provided. Yeah, that's it. We support research, but not every time get involved within a research.
I think the most striking thing that's come out for me there is the community health workers are doing the vast majority of the work, but then they're not being necessarily recognised for this huge amount of work that they're putting in. Dickson, I know that you were a co-author on this paper. You were involved really heavily in this work. What was it like to be involved in this work for you? And reflecting on the findings of it, how does it make you feel that you're putting in all of this work, but it's not necessarily being acknowledged?
As the figures have been put on, if you can see, maybe the larger part of it is about implementation. Right. So, we cannot implement a thing that has not been part of us. So the first thing is to engage the CHWs right away from the planning process to the implementation end. To me, the research activity that I've been involved with CHIC has helped me much. It has sharpened me my knowledge. It has made me to be known by other people who not know me at any point. The publications, the whatsoever has been involved with the research has made me to enjoy the recognition of the world. Again, CHWs are, as they are in deep down in the communities, they've got the most important information that can be needed in research activities. I was saying at a certain point to say there are other activities, even the designing itself, which cannot be fit in the community if we are not involving community health workers. But the involvement itself, it digs deeper what is necessary for the research item to be of much importance. Right. For example, you talk of some of the activities which are maybe not needed by the community. So as a CHW, if you are involved, you are able to see, you are able to check what is important for the community and what is not important for the community. So it's very vital for the CHWs to be involved in research activities because it brings the best thing from what the research would need to be brought about. Yeah, so that's what I can say.
Yeah, those are great reflections. Just moving on now to just talk a little bit about effectiveness. Shobhana, I'd like to ask you, what makes co-design effective?
Gosh,
it's a huge question.
It
but
is.
Just from your like past experiences.
I think there's three things that make co-design really effective. One is about acknowledging the power structures in society, and when you actually do true co-design, you provide the circumstances and the spaces where those power structures are flattened, and you bring people together in this sort of safe space where they can talk about their needs and their wishes. And so I think about acknowledging that power and that everyone has power and agency is a really important part of co-design. And I think what Dickson just mentioned about reciprocity, that often co-design, it takes a lot. So you take all the local, the community health workers can feel that, I think. But actually, what do you get from the process? And if it's acknowledgement, recognition, but also changes to the community that are positive and beneficial to communities. And I think it's also this openness and mutual learning that happens during co-design. And it's contact of humanity, I think, that really makes good co-design. So you get empathy, you learn about the lives of people, and then you can design data platforms, interventions that take into account people's workloads, lifestyles, what's important to them. And when you do that, then the result is going to be so much more powerful and impactful. So I think that that's kind of what I've seen contributes to effective co-design.
Yeah, that's really interesting. We're going to hear in later episodes, especially episode 3 and episode 4 of this podcast, about the use of digital and data quality. And I think the point you've raised there, Shobhi, is really excellent in the sense that you need to make sure that what you're designing is accurate and responsive for the community health workers, to make sure that ultimately the data you are collecting and going to be using within the health system is ultimately as accurate as possible.
We're going to hear now from a colleague at World Bank, Rachel Verney-Neal, who is designing a survey tool to capture the insights and inputs of community health workers for this reason.
So the GFF is working in partnership with our colleagues at Exemplars Global Health, who have done excellent work on kind of what it means to be an exemplary global health program, or CHW program, are developing a new CHW survey instrument. And really the instrument is designed to fill a couple of gaps. So it's designed for governments to be able to quickly check the pulse on the program performance of the CHW program itself. And it really looks at kind of key domains, including supplies, remuneration, kind of community health worker well-being, connections back into the formal healthcare system. The survey is really being designed around some of the lessons learned from the Exemplars program and from GFF CHW investments in the past. And in particular, a recent survey that Exemplars fielded with the Ministry of Health and Sanitation in Sierra Leone and with Last Mile Health in Sierra Leone. And so we took the lessons from that to really develop this global instrument. We're in the final stages of developing that instrument now. And our next phase is over the next couple of months. We'll be taking that instrument to field in a few settings. And we'll be doing cognitive interviews and focus groups with community health workers to really get their feedback on the instrument. I think one of the important things that we're trying to achieve here is making sure that we're also including CHW voices directly in the data that we're collecting. So making sure that their needs, their preferences, their experiences, and their recommendations about how to improve CHW programs are directly built into that instrument. So it will be publicly available soon, and we'll have all of the information up on the GFF's data portal and our Faster Research repository, which you can find online.
Karen, I'd love to just ask you as well, from your experience, I know that Pivot are doing some great work around sort of participatory work and work with community health workers. I'd love for you to share a little bit about that and sort of reflect on why that's so important.
So Pivot is expanding. Historically, Pivot has worked in one district, and we're expanding services to 2 additional districts. So we'll now support a region, and that includes scale up of the community health program. And as part of this, we're really thinking about participatory research. How can we create a research agenda that is a product of co-design that allows us to think about how we measure impact and implementation? It's been an opportunity to bring people together, community health workers, regional and district community health leadership, technical partners, and Pivot implementers, and get everybody in the room to really talk about what are the most important research questions.
That's fantastic. That's fantastic. And Shobhi, just to illustrate for others, can you give an example as to where community health workers were actively involved in co-design? I know that you know some work around empathy and how that can be integrated when you work directly with community health workers.
Yeah, definitely. So I was involved in a project in rural India, and we were designing an intervention for community health workers to screen high-risk pregnant women. And the brief was really around looking at cardiovascular disease, heart disease, and thinking about risk factors for that, like high blood pressure and diabetes in pregnancy. But actually, when we got to the communities and started interacting with community health workers and people, they really didn't have enough food to eat, and it was all about anemia and nutrition. And so through that process of co-design and understanding people's priorities locally, for that one, I changed the complete focus to anemia and anemia prevention. And the community health workers in that regard, they were able to help a lot in terms of understanding the hierarchies within the household, why pregnant women, for example, might be anemic. So often the women didn't receive the food first of all, and other people in the household were fed before. And also about iron tablets. So there was this notion that actually government iron tablets weren't quite up to scratch and they'd prefer to buy them over the counter. And sometimes mother-in-laws had a lot of power within households, so they would have the tablets, and also some cultural beliefs around milk, for example, that it would help with the anemia during pregnancy. So taking that all into consideration and using research methods such as theories of behaviour change, we were able to actually design an intervention that helped to alleviate anemia in those populations because of the co-design and the involvement of community health workers.
Yeah, and those are fascinating insights, especially around purchasing of, say, over-the-counter iron tablets instead of government-administered iron tablets. And when you sort of see the data in isolation, you might wonder why there might be low uptake or spikes in certain purchasing patterns. But it's through that kind of in-depth qualitative work and being actively involved with the community health work is why you understand some of those socio-cultural beliefs, which is really interesting. I know we're having this conversation and we're talking a lot about the involvement of CHWs in co-design. Dickson, from your perspective as a community health worker, do you ever get concerned that, you've already said in episode 1 how much work you're doing? You're doing maternal and child health interventions, TB interventions, you're supervising. How many community health workers are you supervising directly? Is it 19?
Over 30 now.
Over 30?
Yes.
So you're obviously doing a huge amount of work.
Yeah.
Do you ever get concerned that adding an extra expectation to you in terms of true co-design, which might obviously take substantial amounts of time, could ever become burdensome? Or how do you feel about that?
Yeah, actually, it needs to be there. Co-design is the most important thing that should be there. Right now, what I can say is that just because CHWs are not involved in co-design, you'll find that most of the data which is being captured in the communities using maybe the digital tools is not that accurate. Right. Why? The first thing that CHWs are not trained. That's the first thing. And the second thing is about maybe the questioning itself, how the questions were designed. They will not reflect the real issues in the community. So you find that what is being asked on the paper is not existing on the ground. So I think this can bring something that cannot bring any impact in the community, just because we are just going there to see what is in the community, but the communities themselves are not interested on what we have brought for them. So for me, it's a challenge to my facility, to my country as Malawi, and so I know for the rest of the countries who are using CHWs to work, it's a very, very big challenge. But we need to be involved at each and every stage in terms of research activities.
Yeah, and I guess in terms of co-design as well, making sure that you have the time and fair payment. Would that be fair to say? That you've got the space to actually be properly involved in the co-design?
Yes, that's it. We need to be involved, yes.
So we heard there from Dickson about the implications of not involving community health workers closely in the design of data collection tools and the impacts this can have. We can also now hear from Millicent Maruka, a community health worker in Kenya, about how this has impacted her work.
Okay, thank you so much. Let me start by saying that the transition from paperwork to digital tool the time that we were transitioning, but it was quite challenging because for one, paperwork, at times we were using our own language, but in a digital tool, we have to use the English word. And even there are some apps that with us in the remote areas, we don't understand. So it was quite challenging. And another thing is that using English, all of these things are English. And in a remote area, understanding English is somehow difficult to us. So it was a bit difficult, but we continued bit by bit. And to some CHWs, my fellow CHWs, some of them could find it very difficult. Because when, like for example, you may use the digital tool, but at some points, there are some things that even you click, everything has gone. And retrieving that thing may be a problem because if you don't have that knowledge or even that know-how. Because, in paperwork, it was just easy because if you go to the drawer, you find that the paper is not there, you just go back and get the information, you come back.
Yeah.
But with the digital, if everything is lost, retrieving it becomes very difficult.
Yeah.
Yeah. So those are the challenges that we found out.
No, that makes sense. It's a whole different tool you're using. But what would you advise that could have been done differently to help make that process for you better?
The thing that could have been done differently, before they transitioned us from the paperwork, I think they could have, we could have get some trainings, let me say so. Because for one, you'll find that there are some things that we can't do by ourselves, but we need assistance. So from this assistance, we have to get some mentorship to be trained and even get things bit by bit. Like even, in the digital tool, there are some things that even us now, we still don't know. But we need to be mentored.
Like what exactly?
If at all there's somewhere that you click and the information is lost, retrieving that thing for you to find it becomes difficult. Like, let me say that, for instance, there was a time that we were giving out the glasses for presbyopia. After doing this in Kobo Collect, retrieving that thing that that for you to find out that I've given out such and such specs, total number of these specs becomes difficult. So if at all they can be put that, if at all there's somewhere that if you click, you get all the information, that could be better. Yeah.
So it sounds like you would have wanted at the time, and even now it sounds like continued mentorship.
Yeah.
That you can have, new questions addressed just in case you hit up against things. But it also sounds like you wish you would have had a Luo version of your digital tools, or maybe a Kiswahili version, which is also okay. Because I imagine maybe it's easier to disseminate something that's in English, but something in your local language would have been better.
Possibly.
Yeah.
Yeah, I think so.
So.
Yeah.
Okay.
For everyone to understand what is inside.
Yeah.
Yeah.
And that makes sense to me. Yeah.
Yeah, that's good. Yeah, they translate everything in Kijaluo. If it is in English, they translate it in Kijaluo for me to understand it better.
Those were some really important insights, and we're going to hear more about digital integration and transition in episode 3. But for now, let's go back to the studio and hear more from Karen and Shobhi.
And Karen, do you have any examples? I know Shobhi's spoken about some of the sort of best practices and principles. Do you have any practical examples of how this has been done in Madagascar with Pivot?
Yeah. So when we convened, we did a convening around this participatory research agenda that I mentioned. We had our first group convening in the end of the year. And we had to give a lot of thought to how to bring people together, who to bring into the room, how we think about flattening those power structures and really setting a level playing field where everybody is equal. Community health workers in Madagascar receive a stipend for their work, but they're not salaried. But we did want to compensate them appropriately for their time. So we had to think about per diems and sort of how you support everybody who's coming into the room and how you create a culture in which people feel like they have equal voices, where everybody's lived experience and their professional experience is contributing important messages to the work that we're doing. Dickson, I think your message that community health workers should be involved is so important. And I know as a researcher, sometimes I worry it places more work on the community health workers to ask them to come to this meeting. As I said, they're providing essential care in their communities. And so if I ask them to come to a 2-day session to talk about research, who in the community is going to see the sick kid or see the pregnant woman? But it's not a reason not to invite community health workers. I think it's you raised some important points.
Yeah, no, it's really interesting. And I agree, it shouldn't be seen as that excuse not to fully involve the community health workers. I guess we just need to be better as a community in terms of carving out that essential time, space, and importantly, the stipends and salaries that are needed to facilitate that properly.
Yeah, that's true. That's true. Actually, that's brings me to a question that I'll pose to both of them. Would you suggest some of the ways CHWs would be better involved in design of, in co-design of data collecting tools?
I think we've mentioned kind of creating the conditions where everyone's voice is heard and being able to do that. I think a lot of the things that you mentioned as well, Dickson, about being asked questions that weren't relevant to communities. And I think that actually data platforms, they have this dual purpose. One is that actually government authorities might need key performance indicators and might need certain types of data. And those data might not be what the community wants or needs. And so through that process of co-design, we then have that opportunity to get voices heard. And I think then designing data platforms where we're collecting data that are meaningful to communities, but also meet the needs of governments and authorities as well, and funders, which will be there, and we need to sort of cater to both, would be really important. And actually, it's how the data are collected that they're actually meaningful. So a lot of the time we feel when we're collecting data, it's like a tick box exercise, but actually data is transformative. It's a living thing that can actually influence policy and influence communities. And I think when we start seeing data like that and the power of data, then design becomes part of that process. Is actually how do we have a transformative data platform where we feed back those data into communities and actually influence policy decisions as well. I'm not sure if that's answered your question, but I think it's really important to involve community health workers in that process, because generally they'll be the ones collecting the data on a day-to-day basis, and it shouldn't be overburdensome. It should be actually integrated into the daily activities. And in order to get those kind of needs met, I think we have to have those conversations with a wider set of stakeholders as well. So co-design can facilitate that, I think.
And just building on that, Shobhi, I know that you said there could be at odds with different stakeholders who might be interested in different data, types of data. So, for example, you might have government stakeholders who want a particular type of data to be collected, which might be at odds with what the community health workers thinks are important. And I know earlier you talked about creating safe spaces to try and flatten some of those hierarchies. Practically, have you found that is possible from your past experiences, or have there been tensions or challenges? Because I think sitting here in the studio, it sounds sometimes idealistic, just to be transparent and frank, to say, look, we need to flatten hierarchies, create safe spaces. But practically, how do we go about doing this? And ultimately, do governments or the higher power stakeholders win over and their agenda still gets pushed through? I don't know if you've got any thoughts on that.
So I think one example I'll give is around gestational diabetes or diabetes in pregnancy. It was a kind of a real priority for the government to collect data on that during pregnancy, and they developed a model of implementation around type 2 diabetes and things. And so thinking about that in the communities, that wasn't a big priority. But what was a priority was for community health workers to feel that they'd learned a new skill, and to think about how they would do screening for diabetes and pregnancy in communities. So that brings me back to that concept of reciprocity, is that actually, if there are data that are needed by governments, how is that going to benefit and skill community health workers and impact communities? And sometimes it's really hard, but there are win-win situations, and it's about finding those opportunities where those intersect. So what can we give back to community health workers in this sense? So in this particular case, although the prevalence of diabetes and pregnancy was quite low in communities, the community health workers had learnt a new skill. And because of the way that the model was implemented, it involved community health workers working in teams with primary healthcare doctors and the government. And so what was really beautiful about this is that we saw a team-based care approach and actually those flattening of the hierarchies. And I think when people understand each other more and when there's that empathy, then it becomes less idealistic and more practical. But yeah, I think that it can be practical as well.
I think it's a great example. And I think underlying that, a lot of it is about trust and empathy. And I think those are two things that can often go missing under like high pressured situations. But having that central to this whole process is really important. Dickson, I'm quite curious. So I'm sure you must have, you've been a community health worker now for how many years?
19 years.
19 years.
Yes.
So over 19 years, you must have been involved in dozens and dozens of projects and programs.
Yes.
Honestly speaking, have you ever been involved, or have an organization or the government ever come to you to ask your insights and inputs in the design of programs that eventually you end up using? Or is that something that you found has been overlooked traditionally?
No, the correct answer is no. Okay. Actually, what I wanted also to say is that, as we have put it, that I've been involved in different programs and activities. One of the activities that I've been involved in, the data collection that is being done in Malawi. We are calling it IKIS, Integrated Community Health Information System, whereby all the programs have been put in one platform, and you go to the community, collect data from various programs. But what I've noted is that most of the CHWs are not conversant with the technology itself. Why? The other reason is that some of the components inside the application, if I can call that, they are not really reflecting what is on the ground. Right. You find that a community health worker goes in the community, starts taking start collecting data, then he's stuck somewhere, don't know where to go. Right. Then accidentally can delete everything and say I failed to collect data. Why? Mm-hmm. Just because some of the issues that have been put inside the tool are not really reflecting what is on the community. So I think involving CHWs from the designing level up to the end is very, very important, because that will help the activities, the programs to improve. So that's because it has been done as it is supposed to be done.
Yeah, it's really interesting that your answer to that directly was no. I don't get involved in the programs, but equally interesting to know that when you haven't been involved, or your colleagues, and then you have to input this data into the platforms and you get stuck at a certain point, you could just stop at that point and it's a barrier. And then obviously the quality of data that follows from that, or even just the volume of data is not accurate or reflective. So it's really interesting. Karen, just building on the point Shobhi's mentioned, especially, I'm really interested in this point around power dynamics. And we know that the community health worker ecosystem is a really complex web of multiple actors. So it's not just community health workers, it's district health officials, community health officials, international actors. Have you found from your experiences working with Pivot in Madagascar, how do people at, say, the government level react to co-design? Or is it something that is a priority of theirs, or is it often a challenging topic to
I think the government of Madagascar released new national community health guidelines only about a year and a half ago. And I do think there was a lot of learning and a community of practice that helped contribute to those guidelines. And that largely involved sort of high-level technical partners and meetings in the capital city. So I think it's the responsibility of those who are asked to go to those meetings to really listen to the community health workers and to their communities. It's also, I feel like I need to write a to-do list as I'm sitting here, because I think it's our responsibility to advocate for getting a community health worker in the room or some community health workers in the room, and really thinking about how we can revolutionize some of these processes. It's a hard thing to do, I think. And we often act as an NGO, act as sort of the mouthpiece for community health workers and see it as our responsibility to listen and then do some translation of those messages. But I'm reflecting on sort of our role as not just doing that, but also just being much more vocal advocates for engaging community health workers across all levels of the health system when we think about co-design. We presented at an international conference in the fall, and part of our panel discussion, we had a community health worker from Ifanadine district come and present on some of her work. And the conference, the American Society of Tropical Medicine and Hygiene, had various panels and posters presenting on community health research. And for me as a researcher, it was transformative to have her at my side and see that research through her experience. And it just I would say it was illuminating on a whole nother level about how relevant those results might or might not be, how useful they are, and what the actual impact is. I think I hope it was a good experience for her, but I have to say, like, selfishly, it was amazing. It was so informative for me to have her be part of that sort of dissemination process and help help me sort of interpret results through her lens.
Yeah, no, that's fantastic. And I'm really glad both she and you had that opportunity to do that. Often you do go to these like global health. I'm saying it for people who are just listening to this in inverted commas, conferences, and it can be dominated by actors or institutions from global north. And actually there's a lot of bi-directional co-learning that can occur here. And I think as well, it was really nice how you touched upon trying to understand, okay, we have data that's being collected, but actually how is that then being used and how is it being implemented and what does it actually mean within this broader ecosystem is so important. I've had a fantastic time learning from you guys, and it's been amazing to cover all of these topics around the importance of co-design, not only kind of what is co-design, but what does it mean to be done well, and why is it so important to involve community health workers. And again, thanks, Karen, for situating us in the current status quo, which is, unfortunately, at the moment, community health workers are doing so much work, but they're not necessarily being recognised. And Dickson, it's been great to hear your reflections and experience as well, which have been super valuable. And same to you, Shobhi. I would just like to ask both of you, Shobhi and Karen, and actually also Dickson, what's one thing that you take away from this conversation in terms of what has come out of this has been most interesting for you? Perhaps, Shobhi, I'll start with you.
So I think, come back to what Dickson said, is that we need to think about what's actually important to communities, and to make sure that the research that we do is actually of relevance to them, and that anything that we design and the data that we collect is actually of relevance to communities. So that's really come out for me during this.
That was such a great answer. I think co-design can mean a lot of things, and what it looks like might vary a little bit from context to context, but there are some basic principles around how to do it well, thinking about equity and who gets a seat at the table and how you make sure diverse voices are heard. And I think I would not say that we have it solved, but I do think it's part of this learning experience, and that we're committed to doing it better and better as we go.
And that's definitely something that's, Karen and I have worked together for just over 2 years now. And it's something that always comes out so strongly in our conversations. And I think Pivot if anyone's listening to this or watching this and want a good example of how to do things well, Pivot are an excellent example of that. So thanks for all of the work you're doing on that. And Dickson, what's come out of this conversation for you?
Yeah, the best thing that I'm hearing here is about mentioning the name of a community health worker. You can see filter of co-design, whatsoever is being said here, but at the end of the day, you find that the community health worker is being mentioned there. So it's important to value a community health worker because he or she is the one who is bringing everything here to be discussed. So it's very important for me and the other CHWs for seeing that everyone is recognizing CHW as an important part in the health system. For the communities to get what they need, we have to go through the community health work. So I'm glad to hear this from these professionals.
That's fantastic.
Yeah, thank you.
Can I also just finally ask, if you had a funder sat in the room with us and you were trying to say or convince them, if they needed convincing, hopefully they don't have to listening to this, of the importance of co-design and involvement of community health workers, especially in the focus of data-driven CHW programs, what would be your message to a funder?
I think that co-design is essential. It will ensure that everybody's voices are heard, but also that whatever is implemented actually gets implemented. And you get much more meaningful data, much more sustainability of interventions, and much more impact as a result of co-design. So it would be absolutely essential to any program for me.
It makes the process different, maybe sometimes a little longer, a little more iterative. It means that the approach might not be so top down, and there has to be room for sort of unexpected findings and some pivots in the process, I'll say. And so I encourage funders to really partner with those that they're funding to talk about what they're learning through this process and how they can support growth and change.
We hope that you enjoyed this episode. If you did, please consider sharing it with a friend or a colleague and leave us a review wherever you get your podcasts. It really helps others to find the show. And don't forget, episode 3 is now available.